Hi, good evening, everyone. Thank you for tuning in. This is Dr. Maria Sophocles. We're live doing our Gynecollege show. Tonight, we're doing it about recurrent UTIs, which is a problem so many women face. I think I remember reading that about 50% of all women will get a UTI in their lifetime. And for some women, this is a recurrent problem. This is a problem that dogs them, that keeps them from going to social events or keeps them home from work or school, that causes a lot of pain and discomfort. And for some women, this can lead to really complex UTIs, which land them in the hospital. So this is something that has to be addressed. I have patients from 12 to 92 with recurrent urinary tract infections, and nobody enjoys them. Nobody wishes they could get more. So I want to start with a couple definitions. What is the definition of a recurrent UTI? A recurrent UTI is when someone gets 2 or more infections in 6 months or 3 or more infections in 1 year. And as I said, many women can get one and never have another, but for some women, they get into kind of a cycle. And it turns out there are probably reasons for that. And as more and more study is being done on the relationship between the bladder and the vagina and the bladder and the gut, we realize that the microbiome, which is the sort of populations of bacteria that inhabit the gut, the vagina, the bladder. As we look more closely and evaluate these, we realize that there is probably a lot of interaction, a lot of relationship, and a lot of susceptibility to recurrent UTIs that happens in some women and not in others. And we'll talk tonight about why that happens and who this is and what you can do about it. So the incidence, as I was saying, more than 2 infections in 6 months or more than 3 in a year. And I want to talk tonight about some of the risk factors. Okay, there are specific risk factors for UTIs, and I think a lot of people know them, but it's really nice to spell them out. Sex is a risk factor. Having sex drags bacteria from the vagina into the urethra, the opening of the bladder. From there, it can travel up into the bladder, and the female urethra is shorter than the male urethra, so women are at higher risk of getting UTIs in general than men, and women have a higher risk of getting UTIs from sex than men do. Not fair. Exercise is also a risk for UTIs, and this is more likely due to where things like biking, pressure on the urethra, as well as perspiration and hygienic reasons. Holding it, not going to the bathroom. We all know nurses and school teachers tend to be the worst of any professions. They hold it, they have to hold it, they have a long shift, they have back-to-back classes, they hold it, and this leads to bacteria that is in the urethra getting time to ascend into the bladder and invade the bladder wall and kind of get, let's just say, settled in their new home. And the longer you don't void, the less kind of preventative flushing there is of urine, which sort of carries the bacteria out of the bladder. So holding it, not a good thing, a setup for a urinary tract infection. The other risk factors for urinary tract infections include hormonal changes. We know that when women go into menopause, whether that's natural menopause or surgical menopause, the ovaries are removed and the estrogen drops, or chemical menopause from chemotherapy or anti-estrogen medications used to treat breast cancer, all these hormonal changes can wreak havoc on the vagina and the bladder. And believe you me, it's related. When the vagina does not have as much estrogen, there are fewer blood vessels in the vagina and all underneath the bladder. So there is less ability for the blood vessels of the genitourinary tract to clean and carry away bacteria. So we know for sure there's a link between the menopause state and development of less healthy tissue in the vagina and a link to urinary tract infections. Pregnancy also increased risk for UTIs, and antibiotic use. Antibiotics disrupt the vaginal pH. They often will either lower the pH and lead to a yeast infection, or they'll raise the pH and lead to bacterial vaginosis. So then there are pathogenic bacteria that can easily climb up into the vagina. So again, risk factors for UTIs: sex, exercise, holding it, hormonal changes, pregnancy, menopause, and antibiotics. There are also behavioral risk factors for UTIs. We know that sex and frequency of sex and type of sex can increase risk of UTIs. For example, use of spermicide, whether that is with in conjunction with the diaphragm, which I never really see anymore, but I'm sure there are still people that use diaphragms, or spermicide on a condom. We know that the use of spermicide is irritative and can lead to UTIs. There are also what we call urologic factors. Okay, we know there are women who are genetically predisposed, and we know there are women who, whether it's hygienically, have sort of reservoirs of bacteria in the GI tract that then comes up into the perineum and to the urethra, or hygienically they're wiping incorrectly, bringing bacteria into the vagina. We know that most UTIs are caused by E. coli, and mostly that E. coli arrives from the gastrointestinal tract. So there are behavioral factors, there are urologic factors, and there is genetic predisposition, no question. There are women who have sex every day and never get a UTI. There are women who have never had sex. There are virgins and they get UTIs every month. So this sounds confusing, but it helps us understand that we don't have all the answers, and that we need to uncover even more specifically what it is genetically that predisposes some women. We know that anatomically there are women that have anatomic issues or changes that lead to UTIs, but this is uncommon. But what I think is common, and what we'll find when there's more genetic information available to us, is that there are certain people for whom the bacteria is more easily able to invade the bladder wall and sort of stay there. Once it does that, bacteria forms something called a biofilm, biofilm, a biofilm. And it's like this protective shield over the bacterial invasion in the bladder wall. The biofilm can form, and then it's hard for antibiotics to penetrate that. So unfortunately, the more we learn, the more we realize it's no surprise that some women will take antibiotics and either completely treat an infection and then get a new one right away. That's called reinfection. Or they will have a relapse of the infection that's suboptimally treated. There's some little reservoir of bacteria, and the biofilm isn't penetrated, and so the antibiotics fail to wipe out all the bacteria. So this is all interesting stuff, and the topic of a lot of research. Patients ask me often if there are foods they can eat that will help them not get UTIs, and this is really fascinating. And societies like the American Urologic Association do comment that that the relationship between diet and our urinary health is something that needs more research. So I wanted to talk tonight about the most common questions that my patients ask me about urinary tract infections, and I'll try to answer some of them for you. So number one is why do I keep getting UTIs? Well, the reason most women keep getting UTIs is, as I mentioned, a combination of inherited and environmental factors. We know that women whose moms had a lot of UTIs almost always are predisposed to getting UTIs. So we know there's something there. We know that environmental factors can play a role. Use of spermicides, like I said, frequency of sex, holding it, things like that. There are, and we also talked about how the areas of research that are very hot right now are the bladder, the gut, and the vaginal microbiome, and how they all interact, and how that microbiome may be protective or not as far as UTIs. Question number 2 is, what's the best way to prevent a UTI? Is there anything I can do to stop getting UTIs? The number one thing, if you can only do one thing and you want something that's cheap and safe and easy, is to hydrate, to increase your water intake. We know that women who increase their water intake, have regular and adequate intake of water, have lower risk of UTIs. Again, you're filling the bladder more regularly. It's making, with urine, that's then, think of it like flushing a toilet. You're flushing out the bacteria that may be getting harbored in the bladder walls. If you're postmenopausal, the number one thing you can do besides hydration is to make the vagina healthy with vaginal estrogen or vaginal DHEA, or you can use the Mona Lisa touch laser to regenerate vaginal tissue. Any of those things will help indirectly to prevent or to reduce the number of UTIs that you get. How? Because if you make new collagen and new blood vessels in the vagina, then the bladder is better supported. It stays better supported with the new collagen, and you're less likely to have prolapse, which then can allow the bladder to sit at an angle where the urine doesn't empty completely. The other way the vaginal estrogen or the Mona Lisa touch laser will help is that if you have laser treatment or use vaginal estrogen or vaginal DHEA, new blood vessels are created in the vagina, including under the bladder and all around the urethra. Therefore, there's more conduit for the exchange of good and bad cells and good and bad bacteria to be able to optimize the health of the bladder. I've been using the Mona Lisa laser for 7 years, and I've had so many patients who came and got the laser treatment, referred from their urologist. The urologist would send them to me saying, I'm just prescribing antibiotics every month for this woman. You have to do something. We do the laser or give her vaginal estrogen, and the number of UTIs she has in a year will drop from 8 or 10 in a year to 0 or 1. So do not underestimate the power to help yourself if you're peri or postmenopausal, simply by making the vagina healthier with vaginal estrogen or vaginal DHEA, or using the Mona Lisa touch laser to regenerate the tissue. There are other things you can do to stop getting UTIs, or at least to reduce the number of UTIs that you get, or sort of cut them off at the pass. Something that's been studied and looked at is called DMannose. DMannose is a sugar, and DMannose supplementation has been shown in studies to reduce the incidence of urinary tract infections. This is really great because it's an over-the-counter supplement, it's not expensive, and the data is surprisingly good. So DMannose use is something you can try on your own. You don't need to go to your doctor to ask if you should use it. You can try it and see. If you try it for a few months and you don't have the UTI pattern that you were having, then it's working for you. A prescription non-hormonal, non-antibiotic medication that you can use is called Methenamine. And I'm sorry, I should have written that at the bottom, but Methenamine is METHENAMINE, Methenamine. Methenamine is something that we prescribe as a dose of 1 gram a day, and it's taken daily. You just take it every day. You can take it once a day or twice a day. If you get a UTI every month, you probably want to take it twice a day. If you get a few a year, you can take once a day. It's very well tolerated. It's very well studied. It's very safe. It's very easy. Methenamine reduces the ability of the bacteria to adhere to the bladder wall. And that is key in not allowing an infection to form. So again, I have patients who've come to me with many, many UTIs per year. We put them on methenamine, and the number of UTIs reduces dramatically. So Helen has a statement, really, and I'm so glad that you've heard nothing but good things about it. But remember, Helen, if you ask enough people, you'll find someone for whom DMannose didn't work. And it's not because it's not valuable. It's because we are all very unique in what's causing our UTIs and in the genetics we bring to our own little battles of UTIs in the bladder. So methenamine doesn't work for everybody. DMannose doesn't work for everybody. Antibiotics don't work for everybody. So be careful, be patient, and make sure you're in good hands. Make sure you're in the hands of a clinician who truly feels comfortable treating recurrent UTIs. If you have a clinician that's just writing antibiotics over and over and over, I think it's time to look for someone else. If you're getting recurrent UTIs, your clinician should be asking you about your own risk factors. Do you have trouble wiping? Do you have issues because you won't use public restrooms and you hold it? Do you, when did you go through menopause? Or do you have sex frequently? Studies show women who have sex more than 4 times a month are at increased risk for UTIs. And that's okay. It's okay if you have sex more than 4 times a month. That's great. But if you have a frequent sex and UTIs, then maybe it's worth investigating whether your partner is using condoms that have spermicide, or whether you use a diaphragm, or understanding what risk factors you may be bringing to your sexual experience that are actually leading to UTIs. A good clinician will also ask you about the timing of your UTIs. Do you get UTIs around the time of your period? And is that just a coincidence? Well, the answer is no. There is a link and a relationship to UTIs and periods. I'm going to explain it. So if you get so periods, when you have a period, the pH of the vagina rises, all right? When the pH rises, this is a very friendly environment for a bacteria called Gardnerella. Gardnerella is something that lives in the vagina in pretty much everyone. But when the pH rises, it grows a lot and it overgrows, just like a weed. And when it overgrows, women can develop something called bacterial vaginosis, or BV. Bacterial vaginosis can be totally asymptomatic. Bacterial vaginosis is not an infection. It's not an STD. It's just an overgrowth in one or the other type of bacteria. Sounds pretty harmless, right? Well, it turns out it's not. It turns out bacterial vaginosis is associated with preterm labor. It's associated with postoperative infections, and it's associated with UTIs. How? Well, the Gardnerella, as it's overgrowing, can get into the urethra and ascend and can help disrupt things in the bladder, so that the E. coli that you maybe had from a previous infection, or maybe you had just a little bit, not enough to cause an infection, is suddenly sort of empowered to have a full-blown UTI. So there is this bizarre relationship between a period and raising the pH in the vagina and having too much Gardnerella, and that Gardnerella rising and going into the bladder and, inspiring a UTI. So women who get UTIs around your period, you're not crazy. It's not in your head. If you think that's you, document it. Look at it, document when you get your UTIs, and bring that to the attention of your doctor. If they blow you off or they're not sure about the relationship, go to a different doctor, okay? What about women who have IUDs? I've had many patients say, I don't get it. Since I got an IUD, I seem like I have more UTIs. Well, it may be coincidence. It may be that they're having more sex, but also there is a link between IUDs and BV. So it may be that, especially the copper IUD, I'm not a big fan of that, but if you have one and you want it, it's your right to have one. There does seem to be an increase in the association of women with all IUDs, but especially the copper IUD and BV. So if they're getting more BV, that may be why they're getting more UTIs. So these are just things to think about. This may not apply to you, but it might. And it might be sort of an aha moment for you that, wow, I need to address this. Maybe I need to remove my IUD. Or maybe just if I get UTIs around my period, perhaps my doctor can suggest methenamine or an antibiotic or something that I take every month just before my period so I don't get a UTI. So lots of good opportunities. And the more you know and the more empowered you are, the more you can ask your clinician good questions. And hopefully they're really competent at answering them. And together you can be a clinical team and help conquer the issue of recurrent UTIs. I also wanted to talk about the symptoms. So most people know the symptoms of a UTI, but in case you don't, the classic symptoms of a UTI are urinary urgency. I have to go urgently. Urinary frequency. I feel like I have to go every 10 minutes. And a burning sensation when urinating. We call this dysuria. Well, dysuria and urinary frequency are the two most powerful symptoms. If you have dysuria or discomfort when urinating and frequency, those two, dysuria plus frequency, 90% chance you have a UTI, 90%. So kind of a good way to help diagnose yourself, especially if you can't get to a doctor's office. If you have discomfort with urination and you're going frequently, you almost definitely have a UTI. It's always best to go to a clinical office and get an exam. But to be honest, if you can't, you can't. And there's nothing wrong with you if it's you calling an answering service and saying, hey, it's 10 at night. I know you're not open till Monday. These are my symptoms. I really think I have a UTI. Excuse me. Oh gosh, I have to sneeze. Sorry about that. Softer symptoms that might be a UTI. Urine that's cloudy, urine that doesn't smell right, or urine that might be pink or red or have blood in it, or pelvic pain. These are all things that might be a UTI, but are not as clear cut as dysuria, right? That burning sensation when urinating, or frequency, urinating frequency. So any one symptom of those symptoms we just wrote has about a 50% chance of you having a UTI. But dysuria and frequency, 90% chance. So that's kind of a good way to clinically help diagnose yourself or help your clinician diagnose you. What about giving a urine sample? Do we need to do that? The truth is, if you have dysuria and frequency and it's really obvious, you don't necessarily need to give a urine sample. But if you're going to a clinician's office, they will often ask you for a urine sample. They can do two things with this urine sample. Well, three things really. They can look under the microscope, see if they see a lot of bacteria. They can do a dipstick where they dip a little piece of paper, and that tells us whether there's white blood cells in the urine, blood in the urine, protein in the urine, what's in the urine. Because if there are white blood cells, that's another sign of infection, and that's more likely that you have a urinary tract infection. Same with blood. They can also send the urine for culture. They don't really need to do this if you have a very simple, straightforward UTI. When should you get a culture sent? A culture is when they grow the type of bacteria. Well, if you have recurrent UTIs, we have to know what's the bacteria. We have to make sure we're treating the right bacteria. Or if you're a complicated patient, you're immunocompromised, you're on chemotherapy, or you have an organ transplant, or you have a complicated medical history, or you live in long-term healthcare facility where really resistant bacteria grow. If that's you, you really should have a urine culture so we make sure that this is a straightforward UTI and it is a straightforward bug, not something that's resistant to many organisms, okay? In America, we overprescribe antibiotics in general, and because of this, we have developed terrible problems with resistance to many medications for UTI. I'd say Cipro or ciprofloxacin is one of the worst. Lots of doctors order it. It was heavily marketed to doctors. It is absolutely not a first-line medication for UTI. So if you go to a doctor or a PA or a nurse practitioner and they say, oh, you have a UTI, I'm going to order you Cipro. Don't just nod and say, yeah, sounds great. I really am dying to get this treated. advocate. Say to yourself, I know that's an antibiotic, that there's a lot of problems with resistance. I don't want to add to the problem for the healthcare community. And I don't want to risk that if this is resistant to it, I'll be back in here in 5 days with a fever and chills and need a second antibiotic. The 3 most common antibiotics that are listed for UTIs that are used to treat UTIs are trimethoprim sulfate, or the brand name is Bactrim, 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 macrobid, 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 and fosfomycin. So these are 3 used very commonly. Bactrim is a sulfa-containing antibiotic. You take it for about 3 days in a simple urinary tract infection. Macrobid, you take it 5 days. So Bactrim twice a day for 3 days, macrobid twice a day for 5 days. Fosfomycin is a one-time deal, one dose and you're done. These are the most appropriate antibiotics for you. We'll type them up and put it up here so that you can see their names. And these are what most doctors should be ordering for you. Beware, beware, beware of Cipro. Not that it's bad or wrong or dangerous. It should never be the first antibiotic that is used to treat a UTI. Let's see, what else did I want to talk about? Oh, other ways to reduce UTIs. Yeah, so those are the 3 kind of most common antibiotics that you should be offered. Okay, if your doctors or nurse practitioners offering you something different, it's okay to write those down and say, I'd really prefer one of these. There's less resistance to them. Thanks, Missy, for typing those up. So what else can you do to reduce the incidence of UTI? Well, hygiene's a good one, right? Wiping from front to back, making sure you're not dragging anything from the back up towards the front. Acidifying the urine. Acidifying the urine, how? Well, vitamin C is a cheap, easy way to acidify the urine. You can give someone 1,000 milligrams a day of vitamin C. The urine will be more acidic and less prone to UTIs. Well, a lot of patients ask me about cranberry supplements, cranberry juice, cranberry tablets, cranberry syrup, cranberry liquid. There's a lot over the counter, a lot available, and a lot of research has been done on this. Sadly, the reviews are kind of mixed. Some of the studies showed true benefits from cranberry extracts. Others were very mediocre. There are cranberry tablets, supplements, and liquid, though, that are not so expensive. They're over the counter, and I do find this to be another way to acidify the urine. So when I have a patient with recurrent UTIs, I tend to try many things. And one of the things I try is Theracran, which is a cranberry supplement, or other cranberry liquids that people can just take every day to acidify the urine. If you don't want to use a cranberry supplement, again, vitamin C, 1,000 milligrams a day. And then I think I mentioned before about methenamine. This has been a godsend. 1 gram a day of methenamine. Again, this is a prescription, but urologists and gynecologists use it all the time. These are all non-antibiotic ways to reduce urinary tract infections. What about peeing after sex? People ask me that all the time. Well, I just have to pee after sex, right? You just have to get right up and pee after sex. Well, when I trained in the 90s, that's actually what I learned too. But it turns out subsequent studies have shown that if you delay voiding after sex, wait for the bladder to fill. Drink something, drink water, drink juice, drink any, iced tea, whatever drink you like, but fill your bladder and then pee. You will do more to reduce the likelihood of a post-sex UTI. Think about it. Think about it again, if you're peeing and you think about it like flushing a toilet, right? Would you rather flush a toilet with a lot of water in the bowl so you can really get rid of everything, or just a little water? So nothing wrong with peeing after sex, but if you have the wherewithal to think about hydrating, waiting till your bladder's full, and then peeing, you're actually doing yourself a favor, reducing your risk further of subsequent UTI. I hope somebody out there has more questions, because they're really good I love it when you guys ask questions because it helps direct for me what you want to hear. So we started to talk about some of the most common questions I get asked. One of the other questions is what is about triggers? Or these are questions, frankly, I ask patients. What am I doing wrong that causes UTIs? Well, I mean, I call them triggers. In other words, what might you be doing wrong? Is it your diet? We doubt that. We don't know enough about diet. Is it sex? No, nothing wrong with having sex, but it could be that certain positions or certain partners or certain condoms or certain spermicides are causing your UTIs. So see if you can track them. Keep track of when you had UTIs, how often were you having sex, what position, different positions affected, because different positions of sex put different pressure on the opening to the vagina. So most women, when they really pay attention and track it, can find that their UTIs after sexual intercourse happen with certain positions. And then other triggers that can cause a UTI can be travel. Often people who travel will not use public restrooms, or they don't want to use a restroom on a plane, so they're holding it. So, if this is you, you've got to work around that. You've got to figure out how you can find ways to urinate comfortably and regularly. Other women get UTIs when they take antibiotics. That sounds weird. How can you get a UTI? How can an antibiotic cause a UTI? Well, remember what I said is an antibiotic can also cause yeast, and yeast can actually irritate things, and some women will get a UTI that way. We can't win for losing. Lisa Gonzalez has a question. What about a low dose antibiotic before sex? So I love the term low dose, Lisa, because everyone loves to have the lowest dose possible of whatever we want to do. But I think what you're saying is, how about just like one pill, right? Just a little bit of antibiotic right before. This is not crazy. This is done for sure. But remember, the more times we expose our bodies to antibiotics, the more opportunities we have to create resistance. A little bit like the COVID virus, right? The more people who aren't vaccinated, that means the more opportunity there is to get variants that then can unfortunately, we can not combat them with with current vaccines. But anyway, I digress. So why shouldn't you do antibiotics before sex? Well, it's not that it's wrong or it's going to hurt, but by far, it's better to do behavioral measures like delay your voiding after sex and then have a big pee. Taking methenamine before sex. So remember I talked about methenamine as a non-antibiotic way, and you should take it every single day. That's only for women who get recurrent UTIs. For women who just get them once in a while and really don't want to have one ever, I will often prescribe a bottle of methenamine, and they just take one right before sex. If they forget, they take it right after sex. Whatever you do before or after, it's going to help reduce the incidence of UTIs after sex. That is a much healthier thing than the antibiotic. Lots of doctors used to do the antibiotic version of that. Those of us who have trained more recently or just keep up with more progressive current options have switched away from doing antibiotics before sex. So how do you know if you should be someone who takes antibiotics before sex or just an antibiotic every day? Those patients are really, really at an extreme. They're people who have tried all the behavioral measures, all the all the non-antibiotic measures, the DMannose, the methenamine, the cranberry supplements. They're doing all of that, and they're still getting a UTI at least once a month. Those patients probably have what we call reservoirs of bacteria in the bladder that the antibiotics are just not penetrating. And so we think if we just give them an antibiotic every day, this will at least help keep things quiet. And it does seem to work, but you are paying quite a price for that. For example, one antibiotic that we use for those patients to be taken daily with long-term use can cause damaging lung effects. Other antibiotics you just become resistant to. So I wouldn't do the antibiotic before sex unless you've tried everything else, and that is the only thing that works for you. Hope that answers your question. So When people have a UTI and they just can't hold their urine, or they feel like they have to go all the time, and some women, by the way, do get incontinence during a UTI. Usually, first of all, usually UTIs, you start feeling better in about 24 hours. And by 48 hours, most people are feeling significantly better. Should you stop your antibiotics? No, you should take the whole course. But the ability to hold the urine and have urinary function it usually returns in a day or two. If it's not, then the infection might not be completely treated, or you might have a non-infectious issue with holding your urine, overactive bladder, or prolapse, or stress incontinence. So if you've had a UTI, you believe it's treated, and you're still not really able to hold your urine well, that's worth talking to a clinician about and seeing if there are other factors involved. So usually in a day or two after getting treated from a UTI, things should be feeling better and your urinary function should be better. Good questions so far, everybody. So happy you're here, and so happy you're asking the questions. So let's see, what was question number 4, Missy? When I get a UTI, do I have any other options besides antibiotics? Well, yes, you absolutely do. But I don't want to tell people who have a true UTI, don't use antibiotics. So be careful not to misinterpret what I'm saying. If the UTI is fairly mild and we're catching it early, you feel a little something, it's a little bit uncomfortable, no fever, no back pain, no chills, no pelvic pain, no blood that you can see in the urine, just the beginnings of an early UTI, you absolutely can hydrate. You can acidify the urine with vitamin C. You can call and get a prescription for methenamine, and you can wait it out. And you can see, as long as you don't feel it's getting worse, as long as, again, no fever, no chills, no lower back pain, nothing that suggests that infection is climbing towards the kidneys, you're fine. And some people really can sort of fluid intake their way out of a UTI and act aggressively without antibiotics and avoid the use of antibiotics. However, if the symptoms persist, especially if they're getting worse, I think a 3-day course of antibiotics is safe. It's not too much to ask. It's cheap. And I would say, don't be afraid to take antibiotics. I don't want you to think of antibiotics as the enemy. I want you to use them when you need them. I just don't want you to overuse them. Missy, was there a 5th question? I think there's like 5 or 6 questions. Does my diet play a part in causing my UTIs? Again, probably it does, but we just don't have specifics. That's being studied now, and we just don't have enough to really tell you specifics. And I suspect in the future, as medicine becomes more personalized and we'll be able to use genetic analysis, hey, that's my cat, Ruby, who really probably wants to ask some questions herself. We'll know more. We'll be able to tailor and personalize your UTI issue and understand what dietary factors, environmental factors, behavioral factors, and genetic factors are contributing. So for now, I sure wouldn't jump on any, kale and portobello mushroom diet that you read about on TikTok, because I doubt there's scientific data to back it up. 6th question. These are the most common questions my patients ask me about UTIs. So patients say, or one patient asked me this anyway, my symptoms got better with treatment, but they didn't go away altogether. Do I still have an infection? The answer is possibly, but possibly not. So sorry to be cryptic, but let me clarify. If you have a UTI and we treat you, and your frequency, urgency, pain, burning mostly goes away, but now you sort of chronically have symptoms, you could either have a little bit of the infection left, a small reservoir of infection that's just enough bacteria to cause these symptoms, not enough to flip into a whole infection. Or you could have a more chronic condition called PBS, painful bladder syndrome, or IC, interstitial cystitis. Interstitial cystitis. All right. I just want to type that in there so everybody can see it. Interstitial cystitis can be a very painful and debilitating situation where women chronically have bladder pain. And I don't mean just pelvic pain. I mean bladder pain. They come in pointing to the center of their lower pelvis, and they're in pain all the time. It's difficult to treat. It's super frustrating. By the way, we treat it with aloe vera capsules, oral aloe vera. There used to be, and there still are, prescription medications for interstitial cystitis, but they don't seem to work any better than aloe vera. So that's kind of interesting. So if your symptoms don't go away after a UTI, then you may have interstitial cystitis, or you may have a recurrent UTI. You can always go back to your clinical office and ask them to recheck your urine. So question number 7, I think it's our last question. I don't always have symptoms when I'm told I have a positive urine culture. Why is this? This is confusing and strange, but people can have their urine checked and there's bacteria in it. We send it. Sure enough, it grows something, but they don't have symptoms. There are people that have UTIs without symptoms. There is also the opposite. There are people who have bacteria in the bladder, but it's asymptomatic. And the question you should have then is, do I have to treat that? And the answer is no. You actually don't have to treat it just because you have bacteria in the bladder. So those are my kind of 7 most common questions. I think, this is a, just 30-minute segment where we're going on 40 minutes. It's frightening to me how long I can talk all by myself. And you all are very kind to tolerate such babble. But hopefully you learn something and you understand a little bit more about recurrent UTIs, about the antibiotics we use, about the symptoms that suggest it, about ways to reduce the incidence, about behaviorals you can employ, about non-antibiotic treatment. And by the way, if you get a UTI and you're in pain, you don't just need a prescription for antibiotics. Advocate for yourself. Ask for a prescription for a urinary analgesic. What's a urinary analgesic? Think of it like Tylenol or Advil for the bladder, okay? A urinary analgesic is a medication, a pill, that soothes the bladder. It actually decreases the pain in the bladder. It can also make your urine turn blue or orange or red, so you probably heard of them. The most common ones out there are Pyridium, but there's lots, and there's over-the-counter, and there's also prescription strength. So if you've already bought the over-the-counter and it's not helping enough, call the clinician and say, I'd like a prescription strength urinary analgesic. That's about it. I hope I've given you guys a little bit of advice. I hope this has helped. As you know, I am always here for you. You can find me through my website at princetongyn.com. I'm Maria Sophocles. I'm a gynecologist, but as you know, I love taking care of all the kind of related GYN stuff, including urinary health. And it's a really common issue. So don't be shy. Don't be embarrassed. Call us, email us, info@PrincetonGYN. No problem. No question is too dumb. We'd love to help you and take care of you. And now we live in the era of telemedicine, so you don't necessarily even have to come in. We can, oh, I see the cat. Look, check her out. That's pretty funny. Anyway, please be in touch with me if I can help you. We're going to pause on our Gynecollege episodes for a little while, but stay tuned. We will be back. We have so many cool topics to tackle. I think the next one we're tackling is restful sleep, but I may be changing up the dates for that as we get our guests lined up for this winter and next year. That's all for now. Have a great night. Have a great fall, and I look forward to seeing you again. Take care. Bye-bye.